So my name is Ben Kafka. I'll be talking with you today about decision-making in metastatic spine disease. Dr. Barrett gave a nice talk late last year on the overview of metastatic spine disease, but I will be talking more just about decision-making once you have a patient with metastatic spine disease. So spine metastases are very common, potentially devastating complication affecting about 40% of cancer patients, and this is expected to rise as we are having advances in our radiotherapeutic regimens as well as chemotherapy regimens, and so that's increasing the survival of these patients and increasing the chance that at some point during their clinical course they'll develop a spine metastasis. We're also advancing our imaging modalities such that we are probably detecting more of these smaller lesions that we weren't detecting before. And once you have one of these patients, in the vast majority of patients, the goals of surgery are not to cure the patient. The goal of the surgery when we have a patient with metastatic spine disease is to get them back to their systemic therapy in as good a function as possible. And so the main goals are to maintain and restore neurologic function, alleviate pain, achieve spinal stability, preserve quality of life, and prevent local occurrence. And then that is all to get them back to their systemic therapy, which will treat their underlying disease as quickly and in as good a shape as possible. And in the past, these were treated with aggressive surgical approaches, spondylectomies and corpectomies, but the morbidity and mortality rates in these very frail patients were exceedingly high. And so that led to a pendulum shift the other way, which led to patients with metastatic spine disease only being treated with external beam radiotherapy. And this was less morbid and did give some short-term pain relief, but had poor neurologic improvement rates and poor local control rates. And so that led to the development of stereotactic radiotherapy and radiosurgery, which allowed radiation oncologists to deliver tumor-killing doses of radiation to spine metastases, but they did have trouble delivering these doses to tumors that closely abutted the spinal cord, and it did nothing to address the underlying spinal instability. And so then this led to another paradigm shift where the surgeon's goals now are to create space for the radiation oncologist and to stabilize the spine. And that led Dr. Bilski from Memorial Sloan Kettering to design the NOMS framework. And the NOMS framework is really more of a framework and not so much a treatment algorithm. It's a way to organize your thoughts and make sure all the important areas are being addressed when you're evaluating these complex patients. Another important aspect of it is that it's multidisciplinary and it's reproducible. It incorporates radiation oncology, medical oncology, and surgery. And it does this using 4 fundamental assessments: the neurologic, oncologic, mechanical stability, and systemic disease. And I put this up just to show you where we're going. I'll revisit it again later, but this is the overall framework. So the first assessment is the neurologic assessment, and that's the first part of that is a imaging evaluation, and that's to evaluate using a scale created by Dr. Bilski, the epidural spinal cord compression scale. And you look at the imaging, and grade 0 is totally within the vertebral body. Grade 1 is varying degrees of epidural encroachment, and then grades 2 and 3 are considered high grade. Grade 2 has abutment and deformation of the spinal cord with preserved CSF space, and grade 3 has total obliteration of the CSF space. It's also important to look at the patient clinically for signs of myelopathy and functional radiculopathy and the acuity of those deficits, because that can change the aggressiveness and the timing of your intervention. Next is the oncologic assessment. And in order to do the oncologic assessment, you have to have tissue. So when you find one of these patients, it's important, if you have a new diagnosis of metastatic disease, to talk with the oncologist and see where a biopsy needs to be obtained so that you can have tissue and make this assessment. If you have a patient with known primary and newly metastatic disease, it's also important to talk to the oncologist to see if a biopsy is warranted, which may lead to the diagnosis of new mutations that may change the availability of chemotherapeutic or targeted therapies that may change their overall survival. And since radiation is the current most effective and least invasive modality for local tumor control, the oncologic assessment is largely based on that. And so the authors of the NOMS framework looked at multiple studies looking at local control and neurologic recovery rates after radiation, and that's where they assigned things as radiosensitive or radioresistant. And the baseline they use is conventional external beam radiotherapy. And for those who don't know, conventional external beam radiotherapy is just 2 beams of radiation without any conformal techniques. And so lymphoma and myeloma are thought to be exquisitely radiosensitive. and they such that they can even be treated regardless of a neurologic deficit or epidural spinal cord compression because they acutely melt away. Solid tumors considered to be radiosensitive would be things like breast, prostate, seminoma, ovarian, and neuroendocrine carcinomas. Solid tumors considered to be radioresistant would be renal, thyroid, hepatocellular, colon, non-small cell lung carcinomas, sarcomas, and melanomas. And that does not mean that they are totally resistant to radiation. It just means they are resistant to doses that can be safely delivered with conventional external beam radiotherapy and require doses that can only be given with stereotactic radiosurgery. The next assessment is the mechanical assessment, and the spinal oncology study group defines spinal instability as the loss of spinal integrity as a result of neoplastic process that is associated with movement-related pain, symptomatic progressive deformity, and neural compromise under physiologic loads. And it's important to remember that radiation and systemic therapy do not treat underlying instability. And so that's why within the NOMS framework, the mechanical assessment is considered separately. And so to aid diagnosis of neoplastic instability, the Spinal Oncology Study Group devised the Spinal Instability Neoplastic Score. And within the score, you need to recognize the difference between biologic pain and instability pain. So biologic pain is a more diffuse, severe pain in the evenings and mornings when endogenous steroids are the lowest and readily responds to steroid and radiation. And this is likely due to infiltration of the bone with tumor and irritation of the periosteum. Instability pain, on the other hand, is severe movement-related pain that is characteristic of the specific spinal level involved. So then you do your score, you look at the location of the lesion, if the type of pain that's involved, what is the bone lesion, how is their alignment, is there collapse, and is there posterior involvement? And that gives you an idea down here with the total score, is the patient stable, intermediate, or unstable? When you're doing your mechanical assessment, you also need to look at the patient's bone quality. These patients often have gone long rounds of chemotherapy and radiation with poor nutrition, which can drastically affect their bone health. They also may be older and have underlying osteoporosis or renal disease that also affects their bone. And you need to know that before any intervention is planned, because that can drastically change the size or the scope of your intervention. And you can use, if your patient has poor bone quality, adjuncts such as fenestrated screws with polymethyl methacrylate injection to increase their pullouts. And within the NOMS framework, stabilization can range anything from vertebroplasties to multi-level open anterior posterior instrumented fusions, really depending on the degree of deformity and the frailty of the patient. But in general, instrumentation or fixation should be offered to any patient with a SIN score over 10, because it's shown that they lead to superior pain control and quality of life outcomes. Now, you can have a patient with a painful compression fracture that does not meet quality or criteria for instability. And with those patients, you can consider kyphoplasties and vertebroplasties. You can even consider technologies such as radiofrequency ablations or cryotherapies once you've cannulated the vertebra. And there are also other techniques out there that are less well studied, such as expandable jacks or expandable titanium stents that you can place in to help treat painful compression fractures. And this increased availability of these percutaneous techniques have really expanded the number of patients that we can help who may present to you with metastatic spine disease, who may in the past have been too frail to treat with large open surgeries. We can now offer them these smaller percutaneous techniques that can really improve their quality of life. Last is the systemic assessment. This is really just trying to determine what can the patient tolerate physiologically, and it's dependent upon the patient's medical comorbidities, their overall disease burden, their tumor histology, and their ability to withstand the proposed treatment. And again, in the vast majority of patients, treatment for metastatic spine disease is palliative in nature. You're not curing them of their underlying disease. So an estimation of their expected survival and overall risk-benefit ratio are of great importance, because the treatment goals are focused on whether the patient is likely to recover and get back to their systemic therapy, which is actually what's treating their disease. And in order to do this, you need to have an optimal staging workup, which should be in conjunction with the patient's oncologist. Do they need a repeat biopsy? Do they need a nuclear medicine scan? What needs to get done to fully understand the patient's burden of disease? And then they should also be surgical risk stratification in conjunction with the patient's oncologist and internist to determine what the patient is capable of tolerating. Also, it's important to involve the patient in this stage, because patients in varying stages of their clinical course will have different risks that they will be able to tolerate or want to go through with. And there are certain tumor histologies that are indicative of a shortened lifespan, and those would be like metastatic spinal non-small lung cancer, colon carcinoma, carcinoma of unknown primary, and these have all been approximated to have about a 4-month survival. In patients with such short survival, once they have that metastatic spine disease, with limited systemic options, should not undergo extensive intervention because these will need prolonged hospital stays and rehab, which likely won't benefit them with such a short expected life expectancy. And out there, as Dr. Barrett pointed out in his talk, there are numerous prognostic scoring systems to help us estimate the expected survival of these patients, but these are very difficult to keep up to date. They've tried to update them, but again, the technology and the chemotherapeutics are moving so quickly that it's very difficult. So even in our tendency as physicians is to overestimate how long these patients are going to live. And then there's continuing therapies such as reverse tyrosine kinase inhibitors, immune checkpoint inhibitors, vaccine-based cancer treatments, and vascular endothelial growth factor inhibitors. And so it's best to avoid rigid survival prediction systems because these are constantly changing and altering the expected life expectancy. So it's better to have an individualized discussion with the entire treatment team to see if the proposed intervention is realistic and that the patient can recover from the proposed intervention and continue on to their systemic therapy. And in general, if a reasonable pharmacotherapy is available for the post-op period to help control the tumor and their systemic disease is not progressing rapidly enough to prevent them from recovering from your proposed intervention, intervention should be considered. Here's one of those nomograms to try to predict what the overall survival is. This is from the Spinal Oncology Study Group. Here's the Tomita score. Then here's the Tokuashi score, and these again are to try to help us understand how long these patients might live with varying conditions, but they're very hard to stay up to date with current technology. Once you understand, possibly have an idea of how long their expected life is, it's also good to understand how they are doing right now, and you can do that with things like the ECOG score or the Karnofsky Performance Index. And within the Karnofsky Performance Scale, two numbers that are important are 40 for severe disability and 70 is the lower limit of complete self-care. And those numbers are important because the Karnofsky score greater than or equal to 70 is often what's used as entry criteria into clinical trials and large studies. So many surgeons have used that as their cutoff for offering a large open intervention. And in patients with poor performance status, even such as low as 40, treatments such as stereotactic radiotherapy even fail to provide, are too complex and too time consuming, and therapies such as external beam radiotherapy are more appropriate. So here we are back at the framework, and just to run through it a little bit. So if you have a radiosensitive tumor such as breast or prostate and you have low-grade disease, that patient should be referred for external beam radiotherapy. If you have that same radiosensitive tumor but you have high-grade disease, it says they should also be referred to radiotherapy. But in patients with a radiosensitive tumor who are overtly or acutely myelopathic, they are often considered for upfront surgery. Now, if you have a tumor like myeloma or lymphoma, those tumors respond very rapidly to radiation. But tumors like breast and prostate, even though they are radiosensitive, the response does take a while. And so if the patient is acutely myelopathic, it's probably best to undergo an immediate decompression and then refer them for external beam radiotherapy. Now, if you have a radioresistant tumor, such as renal cell, with low-grade disease, that patient needs stereotactic radiosurgery. If you have a patient with radioresistant with high-grade disease, that patient should undergo separation surgery followed by stereotactic radiosurgery, and I'll talk about separation surgery in a second. And you'll see here mechanical evaluation is considered separately, and then all the while you're doing this, you're considering, is the patient able to tolerate the intervention that I'm proposing? For those who haven't seen it, this is an example of stereotactic radiosurgery. So this is a renal cell MET, and you can see these are varying levels of radiation. They're called isodose lines, and you can see here in this purple line you have some tumor ablative dose, and then with dose fall off so that the spinal cord is experiencing some less dose than the tumor. And you can see how conformal that can get. So separation surgery. So separation surgery is indicated for radioresistant tumors with epidural spinal cord compression of grades 2 or 3. And it really stems from the fact that the maximum safe radiation dose to the spinal cord is about 14 gray. And multiple studies have shown that if you give less than 15 gray to the clinical tumor volume, you will have a local failure. And so you can either give 15 gray to the tumor, and the spinal cord will also experiencing 15 gray and likely have some sort of radiation-induced myelopathy, or you can give 14 gray to save the spinal cord to the tumor, and you'll have a local recurrence. So separation surgery is just extracting absolutely just enough tumor to give you 2 millimeters of space between the spinal cord and the tumor to allow the radiation oncologist to give the full 15 gray to the tumor, and allowing room for fall off of radiation to let the spinal cord only experience 14 gray. And the general rule is you have about a 10% fall off per millimeter, and so that's where the 2 millimeters comes from. The other benefits of stereotactic radiosurgery is that it can be given in fewer fractions, can be given in one fraction, and it's thought to have more tumoricidal effects when compared to external beam, because you can get, besides just the double-stranded DNA breaks that you get with external beam, you also get damage to the underlying endothelial cells, which leads to hyperperfusion and cell death. And that cell death leads to release of antigens and cytokines, which is thought to stimulate the immune response and lead to further cell death. And the durable local tumor control rates of stereotactic radiosurgery really make it so that you don't have to resect that much tumor, because the tumor control rates with stereotactic are so good. And so you only need to take out enough tumor to allow the radiation oncologist to deliver those tumor ablative doses. And anything more than that is just increasing the duration of the disease, or increasing the duration of the surgery, prolonging anesthesia, and providing longer chances for possible neurologic morbidity. And so once you give that 2 millimeters of space, the local control rates are the same as a patient with low-grade epidural spinal cord compression, which is about 92% local control. So the general mantra of separation surgery is less trauma, less pain, and a quicker return to systemic therapy. Here's an example of a patient that underwent separation surgery. You have a C6 MET here with high-grade disease, compressing the spinal cord, underwent a laminectomy and fusion. You can see here they gave that 2 millimeters of space, and we're able to deliver, here, this is the 15 gray isodose line here, and the spinal cord was experiencing some dose less than that. Separation surgery with stereotactic is not perfect. Stereotactic radiosurgery has its risks. It has risks of esophagitis, mucositis, dysphagia, diarrhea, paresthesias, transient laryngitis, myelopathy, and radiculitis. We're also finding the more we do this that there are risks of vertebral compression fractures between 6 and 40% of treatments. For reference, external beam has a rate of about 5. And most of these are radiographic and not clinically significant. And we're finding that there seem to be dose dependent, with higher rates with doses above 20 gray. And as you'd expect, there are higher likelihood in older patients with lytic lesions, de novo malalignment, and compression fractures. So in those patients, you can consider pretreatment with vertebral kyphoplasties, or you can just have that patient on your radar and have them closely followed. Often worried about complication of stereotactic radiosurgery is radiation-induced myelopathy, but it's really only seen in about 0.5% of patients, and it's usually self-limited and steroid responsive. In general, the rules that the radiation oncologists follow is 10 gray to 10% of the spinal cord, or a dose max of 14 gray to any singular point. One of the nice things about separation surgery as well is it can be done with minimal access surgeries such as percutaneous instrumentation, mini open approaches, tubular and expandable retractors, thoracoscopy, and endoscopy. There was a meta-analysis done comparing minimally invasive to open surgery with metastatic spine disease, and as you would expect, there was significantly decreased blood loss, decreased need for blood transfusions, shorter lengths of stay, decreased complications with similar neurologic recovery rates. So you get the patient back to their systemic therapy in as good a shape as open quicker. And then the overall outcomes of separation surgery, if you're able to give that 24 gray in one fraction, the 1-year local progression rates of 4% were seen, and that's regardless of tumor histology. In a longer-term study comparing separation plus stereotactic versus surgery alone showed that the separation surgery group had longer overall survival, increased performance scores, decreased pain at 26 months. Another study showed that patients undergoing separation surgery had decreased pain at 3 months, improve activities of daily living, enjoyment in life, and overall mood. And the local control rates after stereotactic radiosurgery from separation surgery is independent of tumor volume. So you don't need to take any more tumor out than what you absolutely need to give that 2 millimeters of space for your radiation oncologist. And here's a chart, data that tells the radiation oncologist how much radiation they can give to each specific organ at risk in their different fractionation schemes. Just so you know, this is out there, but they know how much radiation they can give to the spinal cord, the cauda equina, the brainstem, and the brachial plexus. And it's important to have a discussion with your radiation oncologist to identify the organs at risk and how much space and where do they think they need more room. So a few other questions that may arise when you're treating these patients is the timing of the surgery. And just like acute spinal cord injury, it's really dependent on the severity and the acuity of the deficit. In a patient with an acute deficit, every effort should be made to intervene within 4 to 8 hours because that has been shown to correlate with improved outcomes. And then the timing of radiation. So radiation can impair wound healing after surgery. And sadly, though, there is a lack of uniform reporting. In a review of animal literature and adult studies says that about 1 week for optimal wound healing. A different review of the literature said that optimally you should wait about 2 weeks with a minimum of 7 days. And it's been shown too that postoperative radiotherapy is much more tolerated than preoperative radiotherapy. So those are important things to consider. But overall, I think the NOMS criteria is a nice way to organize your thoughts and to make sure all these areas are being addressed and to make sure that all disciplines are involved in the care of these complex patients. That's all I've got.
That was awesome, Ben. Thank you.
Great job, Ben.
Yeah.
Yeah, thank you, Ben. Great summary.
Any questions from anyone on the call? Hey, Ben, were they using this back home for you? Like, was this part of?
Yep, we had one of our oncology attendings had just come from Memorial Sloan Kettering, and so she brought it, and that's what we've been using.
And then was this part of like their multidisciplinary meetings when they had them? You know, was the shared decision making that occurred in the setting of like the oncology board? Or
Yeah, we have a weekly tumor board, and the imaging was shown. The radiologist would describe the imaging, and then there'd be medical, radiation, oncology, and then neurosurgery, and we'd go over everything and make a plan.
That's cool.
Yeah, I mean, I would just add that like this is super important work, and it's not universally followed, I think, in clinical practice because it's so new. Like I remember when I was a resident, unless it was myeloma or lymphoma, if there was cord compression, we would just operate, which is like totally, oblivious to all the different cancer biologies. So it's just great to have sort of not, the word algorithm isn't an awesome word, but like to have a lot of guidance into how to sort of best treat these patients. So when you go out into practice, you probably have an opportunity to kind of educate some of your colleagues potentially about how useful this is.
Yeah, no, I think so. We've seen good results with doing it, and people seem to do better with less surgery, obviously, and get to the actual therapy that they need.
Awesome.
That's a great talk, man.
Cody or Micah, you guys got any questions about this whole process as you're going into your practices? I think this gets challenging in a private practice scenario because you have different people taking call within a healthcare system, so that there's not an oncology team. And I think is, in my opinion, one of the downsides of having that sort of environment, because you lose out on some of the multidisciplinary input that makes this shared decision making so important and provides sort of the best care for these patients. And so a lot of times it's just dependent on if a radiation oncologist gets consulted first, or if you do, or et cetera. So I think in the private practice environment, it really depends on which medicine doc's on call that comes in with the metastatic spine disease, if it's something that comes into the call pool. Certainly the outpatient stuff's a little bit different because they can direct it towards the surgeons that are interested in doing this type of work, and sort of the tumor boards become more effective. But like you mentioned here, typically what we're dealing with is mechanical instability and neurologic injury, and so that setting, it's almost always, not almost always, but like so much of this is coming through the pathway of the urgent care or emergency room, or an urgent consult, something like that.
Yeah, and that does make it a lot more difficult to get everybody involved quickly.
Yeah.
But it's a great point, Greg,
Yeah,
because like the onus is on the surgeon primarily. And Micah and Cody, it's good for you to kind of appreciate that. Like the oncologist is going to be like, hey, I got this patient that has, spinal cord compression, but don't worry because it's small cell and it's probably radiosensitive. They're going to be like, cord compression, spine surgeon. Do they need spine surgery? You know what I mean?
Yeah.
And so you're going to be the only one that's be like, well, we've got this set of guidelines that accounts for you know what I mean? You're going to be in the driver's seat. Regardless of whether or not that's the most appropriate thing, that is where you'll find yourself. So you have to kind of know this stuff.
Maybe. Yeah, maybe. But I think what helps is Cody and Micah, you go out, is to get involved with the hospital's tumor board. Even if you're in a community setting, generally there still is a tumor board, and introduce yourself, participate in the meetings, ask to be present if they're going to have spinal oncology cases, and then you can introduce this metric into the tumor board's way of thinking about things. So then it doesn't matter if it's you who gets the first call from the ER, if it's the oncologist or the radiation oncologist. Hopefully everyone will be in alignment with patient care.
Awesome. Well, thanks, Ben.
Thank you, Ben.